This is an introductory lecture to the diagnosis of bone tumors. One of the first considerations in looking at a bone lesion is whether it's primary or secondary. This is important because these types of tumors behave differently and are treated differently. Parenchymal organs usually give rise to carcinomas. So these are the cells of origin for carcinomas or adenocarcinomas, like prostate, thyroid, breast, lung, and kidney. So these are more commonly your metastatic lesions. Hematopoietic cells, like lymphoid and marrow-derived cells, produce myeloma and leukemia. And sarcomas derive from mesenchymal cells, so the connective tissue cells. And it's important because sarcomas behave differently. They're much more aggressive in how they affect the bone, often in the host as well. And their metastatic pattern is different. They have a hematogenic, not a nodal metastasis. So sarcomas tend to metastasize to the chest and lungs, and that's in contrast to the parenchymal cells of origin, such as the carcinomas, that tend to have nodal metastases. This imaging is very helpful in understanding the difference in histology. So carcinomas, again, arise from the parenchymal organs and tend to recapitulate the organs they come from. So the slide image on the far left is showing you nests and glands of cells. In the middle is a hematopoietic tumor. Myeloma or leukemia would look like this with small round blue cell tumors. If you look at the image in the middle, there are large areas similar to bone marrow. So hematopoietic tumors often derive from the bone marrow or bone marrow cells and have an appearance that recapitulates bone marrow. There's very little stroma around the cells. Again, they're small round blue cells. They're discohesive. To the far right then is a sarcoma, a dense stroma, a dense spindle and cigar-shaped cells with large, bizarre pycnotic nuclei. And as you look, these look much more like muscle cells or bone cells, the cells that they originate from. Sarcomas behave differently, and that's important. They look different, and their pattern of spread is different. Another very important consideration to be made is the age of a patient at presentation. Now, this is the way patients present to you in clinic. The first thing you're going to know is the age and some other factors about the patient. But if you break this into a couple of big categories, whether patients are less than 5 years old, less than 30 years old, or greater than 30, you can often make the diagnosis just based on a differential. So if you look at bone lesions less than 30, you can see this is what the majority of bone lesions compromise. Your malignant lesions like Ewing sarcoma and osteosarcoma can be seen in this category, but also Langerhans histiocytosis, metastatic rhabdomyosarcoma, etc. Become important by the age. And in contrast, if you look at bone lesions in patients greater than 30, there aren't that many, and they're pretty specific. So your primary malignant bone tumor in a patient over 30, a chondrosarcoma, a lot of bone lesions you will then see are metastases: prostate, thyroid, breast, lung, kidney, lymphoma, and myeloma. Chordoma is more common in the over 30 age group. And then adenomatomas, giant cell tumors, and Paget's disease. Patients will also present with some sort of history, and in talking to the patient, you may find that their pain is very important to the story. Pain may come from a pathologic fracture. A patient may very well know that they broke the bone, they have severe pain, or they may have a pathologic fracture that hasn't displaced. All you have to have is a bone lesion and associated pain to have a pathologic fracture. The fracture may or may not be displaced. There may also be pain due to compression from tumor volume. So as the lesion begins to work its way out of the bone before destroying the bone or creating a lytic lesion, it may be expansile in the front from that, with the edema swelling alone may cause pain. There also may be a mass that the patient has noted, and there may also be findings on history or physical. Very few labs are important in this scenario, but there are some that should be considered. Pain is important in considering the diagnosis of a bone tumor. Pain that is not associated with trauma, so a patient that's sitting into a chair, standing up from a chair, getting off the toilet that fractures a bone, a low energy mechanism, has to be considered for a pathologic fracture. This may be from a malignant tumor. It could be from a benign lesion. Osteoid has a very specific pain pattern, so it's very easy to test and should be easy to pick up in the history. It's diurnal, so it occurs at 2 in the morning, 2 in the afternoon, so usually twice in a 24-hour cycle. The pain occurs at night oftentimes, and a patient will wake up with excruciating pain at the same time every night. Parents will say they can set the clock as to when the kid's going to wake up and have pain. They've usually figured out if they give the kid an aspirin or Motrin or ibuprofen before bed that they will sleep through the night. And that's very important because aspirins and NSAIDs are part of the prostaglandin pathway that osteoid-osteomas incite, and by breaking this pathway they alleviate pain. Soft tissue sarcomas, on the other hand, are deceptively painless. So just because a mass is large and a patient doesn't have pain doesn't mean that they don't potentially have a malignant problem. It's very important to take as thorough a history physical as anything for patients, because you may find everything that you need in diagnosing them in that. So presentation or history includes a discussion of the pain. Pathologic fracture, displaced or non-displaced, can cause pain. There can also be compression due to tumor volume. Lymphomas can get really big without destroying the bone, but they cause severe pain because they expand so quickly. They create a large soft tissue mass. A pathologic fracture is diagnosed when there's a lytic or bone lesion and pain. So any sort of bone lesion that is causing pain creates a path fracture. Now, whether the fracture is displaced or non-displaced is sort of a terminology difference. We can also use the term impending in the same sense as displaced. So a bone abnormality or bone lesion associated with pain is a path fracture. If the bone is angulated, displaced versus non-displaced, again, a terminology difference. Here's an example of a non-displaced pathologic fracture, and you see the red arrows are showing you a lesion in the greater trochanter extending down below the left trochanter. You can see this better on the lateral view. This patient has a lytic bone lesion and they have weight-bearing pain and pain with any pressure on the bone. So this is a pathologic fracture. It just hasn't displaced. Here's an example of a mass creating a problem for a patient. So patients will present with a difference in range of motion in joints. So this is a patient who is getting on the floor, getting their legs in a crisscross position, and can't do so because the left knee does not bend as far as the right knee, and people will notice a range of motion decrease over time. So the actual mass, although painless, which this mass is, may not be the presentation, but a lack of motion or feeling of mass may be the inciting reason for presentation. And that's important. It's important to know if the patient isn't having pain, but they've just noticed a large painless mass. There are also incidental findings. So this patient presented with right-sided rib pain, and it was noted in the proximal humerus that there was a bone lesion. A better image captures the entire bone lesion. This is a patient who never had shoulder pain or discomfort, and it's important when you see this cartilage-based lesion. This is an enchondroma in the proximal humerus. It helps in the history that the patient does not have pain and has never had pain, and the lesion was just incidentally picked up in imaging for another reason. Here is a patient who presents with knee pain. This patient has tricompartmental arthritis, and it's incidentally noted that the patient has an enchondroma. The pain is attributed to the arthritis, and the patient just incidentally has a benign cartilage lesion in the distal femur. Cartilage lesions change the bone architecture, and here, if you're able to cover up the cartilage lesion with your hand and look at the architecture of the bone, it's completely normal except for the arthritis surrounding it. Lesser troch fractures are important. Often they can be non-displaced. So here the red arrow is showing you the lesser trochanter. Sometimes it's better seen on the lateral view that this patient has a non-displaced pathologic fracture of the lesser trochanter, and this is pathognomonic for cancer until proven otherwise. Here you can see the imaging. Now the patient has displaced, so this would be a displaced pathologic fracture. The MRI scan on the right actually shows you the fractured bone that is pulled off and a soft tissue mass back behind it. When you biopsy this patient, you see malignant glands invading mature bone. So as we talked about in the second slide, when you look at this histology now, You don't have cells that appear similar to bone marrow that are small round blue cells, or cells that look like muscle. You have nests and glands invading normal mature bone. So the top left part of the slide shows you very mature bone with all the lamellar lines and lacunae in it, and then the cutting cone of the malignant lesion eating into the bone itself. So you want to treat these, and you need to treat these because the bone is brittle and it doesn't heal, especially if a patient has pain. So if a patient presents to you with unilateral leg pain, you get an x-ray and you see a bisphosphonate-induced fracture, you first want to x-ray the opposite side to see if there's another fracture on the other side, and then you want to sign the patient up for surgery. Here's an example of a patient who had a lack of trauma. They were having weight-bearing pain, and the pain was getting progressive and getting worse. Taking a personal history of cancer, so a patient who has a history of cancer, even if it's 20 years remote, has a very high likelihood of having metastatic cancer. A radiation history is very important when you're taking the history. Bones can be affected by radiation even if the breast or some other area has been radiated, especially the pelvis. We see this commonly for radiation in the breast or radiation or the prostate, that patients will get radiation-induced fractures or radiation-induced osteonecrosis. I told you medications are very important in the history, especially bisphosphonates. Corticosteroids are also important because patients can get corticosteroid-induced osteoporosis. And then your physical exam still remains important. The prostate, the thyroid, the breast are all places you can examine and may find a lesion. Lymphoma may have adenopathy. So taking a good history, asking questions, doing a good physical can often unveil the source of an underlying lesion. This is a patient who presented to me, and she had seen 2 physicians before me. No one had examined her breast to find this fungating breast lesion. She clearly had metastatic breast cancer now that we knew she had a large fungating breast mass, or a diagnosis was made just on a history and physical exam. Here's a patient who presented with a lytic humerus lesion, and just on physical exam he had a significant smoking history and clubbing of his fingers, as is seen with years of smoking, and it was easy enough to diagnose him with metastatic lung cancer. So as we follow this pattern, doing the good things doctors do, that good doctors do, history, physical, imaging, staging, biopsy, treatment, imaging is important to go back to the very basics of imaging. You want to image and do a plain x-ray including the joint above and joint below of the primary site. CT scan may be helpful in certain instances like osteoid osteoma or osteoblastoma, an MRI scan, and then a biopsy. So local staging involves just the bone lesion at hand. Systemic staging includes a whole body bone scan, a chest x-ray to look at the chest, obviously, CT chest, abdomen, pelvis, and potentially labs. So it helps to know the order of evaluation. You want to do a history and physical. It's simple. You always want to talk to a patient before you move on, doing local staging, systemic staging, because you may very well find your answer, making it easy when you go in for the biopsy. Pathology doctors are working with a limited amount of tissue and a small amount of tissue, so you want to help them as much as you can. If you can go in and say there's a kidney lesion and now we have this lytic bone lesion and the likelihood is renal cell carcinoma, it's going to be a lot easier to help them make a quick diagnosis for you if you're taking the patient to surgery. It's also really important to have a diagnosis before you treat. It's important in practicality, and it's important for your exam. So don't ever answer a question or presume to treat a patient without having a diagnosis. So for local staging, these are the tests of choice. Remember, a plain x-ray in 2 planes, including the joint above and the joint below. Seems simple, but it gets missed. And a patient may present to you from outside and you overlook getting a good image of the joint above and joint below. So these are the 4 questions that you want to ask based on plain x-ray. Dr. Enneking, who's one of the greats of orthopedic oncology, had these 4 questions, and if you start with these based on a plain x-ray, you often will be able to get yourself down to a good differential diagnosis. So what is the location of the tumor? And this means epiphyseal, metaphyseal, diaphyseal. What is the tumor doing to the bone? And what's the bone doing to the tumor? And then what's the matrix of the lesion? These give you an idea, because a lot of tumors only occur in a certain location. Giant cell tumor of bone prefers the metaepiphyseal portion of bone. What is the tumor doing to the bone? Bone doing to the tumor lets you know how aggressive the lesion is or not. If the bone is expanding over time with the lesion, it's probably less aggressive. And then what is the matrix of the lesion? Can give you a good clue as to what is happening with the tumor. Here's an example. If we say, what's the location? Well, this lesion is metaphyseal. It's in a skeletally immature patient, which becomes important. What's the tumor doing to the bone, and what's the bone doing to the tumor? Well, the red arrows show you a very large soft tissue mass moving outside of the bone. But if you look at what the bone is doing, the bone is not responding in an extraordinary fashion. There's some bone being made out in the matrix of the lesion, but the cortex is relatively intact, which lets you know that the lesion is very aggressive. It's moving significantly faster than the bone. And then that underlying matrix, what is that? Well, when you look in the metaphysis and in the outer soft tissue mass, you see bone. So it's a skeletally immature patient with an aggressive bone-forming lesion, osteosarcoma. So when we talk about tumors and their location, so location, tumor bone, bone tumor interaction, and matrix, we look at the epiphysis, metaphysis, diaphysis, flat bones, spine, and sacrum. Now, it's helpful to remember bone tumors this way or how they present because this is how you see a patient. The patient comes in, you take a history, you do a physical, you get an x-ray, and the first thing you're going to do is look at the x-ray and start asking yourself these questions, the four big questions of Eniking. And here's that first one, what is the location? We talk about epiphyseal tumors and epiphyseal location. There are three common things that occur here. Chondroblastoma is what we see in a skeletally immature patient. So a skeletally immature patient with an epiphyseal lesion, first consideration chondroblastoma. In a skeletally mature patient, giant cell tumor. And then the oddball is a clear cell chondrosarcoma that very commonly occurs in the femoral head. Now this is a very uncommon lesion, but it has a very common appearance when it does occur. The hands and feet, just a consideration for the epiphysis. If you look at the metacarpals and the thumb in comparison, you will notice that the epiphysis is the reverse. So look at the phalanges here and the thumb with the proximal epiphysis, but in the metacarpals themselves, the epiphysis is distal. Metaphyseal lesions, osteosarcomas, chondrosarcomas, and metastases. And then diaphyseal, adematoma, adenocarcinoma, Ewing sarcoma, infections or histiocytosis, osteoid osteoma, osteoblastoma, fibrosdysplasia, lymphoma, myeloma. So AEIOU and sometimes Y. And then the flat bones. The skull, sternum, ribcage, scapula, and pelvis comprise the flat bones. And things that commonly occur here, hemangiomas, fibrosdysplasia, chondrosarcomas, Paget's disease, Ewing sarcoma, and of course metastases, including lymphoma and myeloma, can occur anywhere in any bone. When we particularly look at the spine, the anterior elements are common to have giant cell tumors and Mets. The posterior elements, osteoid osteomas, osteoblastomas, and aneurysmal bone cysts. The picture on the bottom right here is a large posterior spinous process lesion. This was an osteoblastoma. The sacrum considerations here are for lesions that are eccentric or central. Here we see an eccentric lesion. So when you're looking at the spine on the right side, you see this eccentric lesion. Same on the axial view to the bottom right. This is more common for aneurysmal bone cysts, giant cell tumor, and metastases. This is in contrast to the confusion lesion, the chordoma. So chordomas have a very characteristic appearance, shape, and a very characteristic histology, and they are far more common to be very central, very centralized, well contained, and much more organized than a metastatic lesion is. Here you see the lateral view of the chordoma. Again, it's very well organized in how it is growing. It is filling the canal and then almost looks like a ball on the front of the lesion. You can see how easy it is if you incompletely image. So we talk about getting the joint above and the joint below. You also want to make sure that when you image a lesion, you get all of it. If you look at the very bottom tip of this lesion, as you start to move towards the coccyx, you will begin to see the chordoma, which almost missed. Same thing here. If you look at the very bottom of the lesion, you almost miss this chordoma because the pelvis wasn't fully visualized on this image. Consideration should also be given for surface lesions. There are low-grade surface lesions and high-grade surface lesions when we're talking about bone tumors. This is a parosteal osteosarcoma. It's stuck on bone. This is in contrast to the periosteal osteosarcoma, which really, in consideration, arises from the periosteum. There's a difference in the two histologically. There's a difference in how they behave and the overall prognosis. A parosteal osteosarcoma sits on the surface of the bone. It does not invade the cortex itself or the intermedullary contents. It is a very low-grade lesion with a low-grade histology. A periosteal osteosarcoma is a high-grade surface lesion and should be considered similar to that of an. Here's the example of that. The blue arrow is showing you the lesion essentially rising from the periosteum, extending out from the periosteum towards the quadriceps muscle, creating that sunburst appearance we often talk about with osteosarcomas. When we talk about considerations for surface lesions, parosteal is a surface lesion actually stuck on bone. The mineralization starts centrally. As the tumor grows, it gets bigger. In contrast, myositis ossificans is juxtaposed to bone, but it doesn't necessarily contact the bone. The mineralization starts peripherally. This is important. So malignant lesions tend to start small, grow, and that's the same thing their mineralization does. In myositis ossificans, you have an injury and a bleed, and the body has to attack the hematoma from the outside, so it calcifies and sort of contains it and walls it off, and then begins to resorb it and heal it from out to in. And in contrast to both, an osteochondroma, a benign lesion that is confluent with the intramedullary canal. So when you put these three side by side and compare them, they look quite different. So special consideration for the location, hands and feet. Enchondromas are the most common tumor to see in the hand. The lesion in the upper right is a phalanx with a cleared out area with central calcification, arcs and rings, popcorn nuclei. Another special consideration, the calcaneus and talus is a great place to see a chondroblastoma. It's unusual, but just a special caveat to remember. So we've talked about location. We can talk about what the tumor is doing to the bone, what the bone is doing to the tumor. The tumor-bone interaction was described by Lodwick, and it looks at basically the progression of a benign geographic lesion to a very lytic, aggressive, destructive lesion. And it's not as important to understand each type and terminology and how they go, but to get an understanding of what a lesion does and how it appears to understand if it's benign or not. So a geographic lesion is a very well described, defined lesion that you can basically take your finger and draw a ring around. An example of a lesion with a sclerotic border would be a non-ossifying fibroma. Moving from distinct to indistinct goes from a unicameral bone cyst to a giant cell tumor. Moth-eaten describes something like metastatic disease, where it looks like there are small little pits in the bone over time. And a destructive lesion, or a type 3 aggressive lesion, would be a Ewing sarcoma. So here's a geographic lesion. And you can see that if you take your finger and draw it around the lesion, it doesn't have that sclerotic rim to it, but it does have a distinct border to it. So this is a unicameral bone cyst. As we move on, we see a much more moth-eaten appearance. You can see that although the lesion is somewhat expansile, it has these pits or holes in it. And then as you move on, the lesion becomes significantly destructive, just destroys the bone. There's absolutely no reaction to the bone. And as you move through these, you can see that the lesion becomes more aggressive and more destructive of the bone. So once we've looked at the location, tumor-bone, bone-tumor interaction, we want to know what the matrix of the lesion. So the matrix can tell us a lot about the lesion. There are some matrices that are easier to see, like bone, where you see the mineralization associated with an osteosarcoma, osteoidostoma, or osteoblastoma. There's also the calcification or dystrophic calcification seen with chondrosarcoma and cartilage. There's fat and fibrous tissue, fat in an intraosseous lipoma, and fibrous tissue and fibrous dysplasia. Fluid may be seen in aneurysmal bone cysts or unicameral bone cysts. And then the other lesions, Ewing's, Mets, giant cell tumor infections, may not have a discernible or definable matrix. Here's an example, again, of asking our 4 questions. What's the location? Metaphyseal. What's the tumor doing to the bone? And what's the bone doing to the tumor? You can see that there is a bit of a Codman's triangle where the arrow is forming. There's a soft tissue mass pushing out of the bone. So this is a skeletally immature patient with a very aggressive appearing lesion. And what's the matrix? Well, if you look through the tibia, you can see that bone is much more dense than any other bone on the x-ray. This is a bone matrix. So a skeletally immature patient with a very aggressive appearing lesion, that the tumor is doing more and far more active than the bone is, osteosarcoma. Here's another example of bone matrix. This is a skeletally immature patient with a metaphyseal bone lesion. The red arrow is showing you a Codman's triangle. The green arrow is showing you the hair on end pattern we discussed. And it's a great slide because you see both. You see that Codman's triangle with the periosteum being lifted and then attempted healing in layers. And on the right, you see where the bone matrix is being formed here. Now, the central part of the bone is also quite sclerotic in appearance with that mineralization and malignant mineralization occurring. So, a skeletally immature patient, metaphyseal bone lesion, extremely aggressive, where the lesion itself is far more aggressive than the bone is. So, the tumor bone tumor interaction is far more aggressive in favor of the lesion. And then the underlying matrix is bone, again an osteosarcoma until you prove otherwise. Here is a metaphyseal lesion as well. What's the tumor doing to the bone and what's the bone doing to the tumor? Well, you can see that moth-eaten appearance here in the bone then. You see there are areas where the bone is just being eaten away, and the bone is doing absolutely nothing. It's being completely overwhelmed by how aggressive this lesion is. And when we ask what the matrix is, well, it's not bone, it's not cartilage, it's not fat. It's one of those sort of amorphous matrix that make a lytic bone lesion. So this is likely a metastatic bone lesion, especially if you find out that the patient's over 50. Cartilage is another characteristic matrix. The dystrophic calcification that occurs in cartilage creates arcs and rings around the binucleate cells that make up cartilage. So not only location being important for a flat bone, here being a scapula, but instead of the smoother mineralization that occurs, you see the punctate calcifications, arcs, and rings that make up cartilage. Here's another example on the left is a benign lesion, an enchondroma. You can see if you covered up the lesion and looked at the overall bone architecture around it, you would see a normal cortex. The central lesion is very well defined and has the arcs and rings of dystrophic calcification and cartilage. On the right is a far more aggressive lesion. If you cover up the lesion and you can't see the cartilaginous matrix, the bone itself is abnormal. It has grown and expanded and changed over time. In the middle of that then are these clumps of cartilage with lucent areas that have not yet had the dystrophic calcifications through them. This is where you get the endosteal scalloping and endosteal erosion commonly seen in cartilage lesions, especially malignant cartilage lesions. What about a fibrous matrix? Well, fibrous dysplasia is the lesion you see on the right, and we talk about the ground glass appearance of fibrous dysplasia. And the image on the bottom left is ground glass. So when glass, either a frosted edge of a slide, if you remember looking at slides in pathology in medical school, or histology, or here where you have basically frosted glass or ground glass. The glass is ground up, and then as it remelts to form a pane of glass, you can't quite see through it. And what happens is that instead of having marrow that's full of fat, you have this fibrousy, thick tissue, and instead of having an image that goes through 2 cortices, you're essentially going through 2.5 cortices. So you don't see the normal lines through the bone because it's full of this thick, dense fibrous dysplasia. And this, again, is the ground glass appearance we talk about. It almost looks like the bone has been smudged. We talk about fluid. This is an eccentric aneurysmal bone cyst. So aneurysmal and unicameral bone cysts both fill up with that straw-colored fluid. There may be fluid levels or fluid channels where there are very thin septae of bone that go in between the cystic area and then fill with fluid. Hydrostatic pressure creates this. And then you have other matrices. This was a highly aggressive malignant Ewing sarcoma in a patient. And you can see when you talk about location, it's epiphyseal in a skeletally mature patient. The patient had such an aggressive destroyed lesion extending up into the metaphyseal, diaphyseal part of the bone that it completely destroyed the bone. But there's no discernible matrix here. It's not bone, it's not cartilage, it's not fat, it's not fibrous. And often this leads to the requirement of a biopsy. So once we've talked about x-ray, well, once we've done plain x-rays and looked at the lesion in question, part of our local staging then can be other scans and images. A CT scan is great in local staging when looking at a bone matrix or bone architecture, and in particular, it's very good at looking at osteomas. It's superior for mineral detection, and if you look at the image on the bottom right, the blue arrow is on the normal cortical bone. The red arrow is on the osteoma, which is an intracortical lesion, and you can see how as it forms itself just at the edge of the cortex, it then really irritates the periosteum. Usually, again, it's a patient under 30 that has a very robust periosteum, and the green arrow then shows you the irritated bone irritating the periosteum, creating woven bone. So if you look at the blue arrow, that's a very dark, dense cortical structure. And as you look at the edge around it, you see the lighter gray woven bone that will later mineralize when the osteoma has been treated, most likely with radiofrequency ablation. Standard of care for treatment of osteoma, radiofrequency ablation. An MRI scan is great for local staging because it tells you a lot more than plain X-ray or even a CT scan. It evaluates the extent of a soft tissue mass. It can tell you if there are skip mets. And we often say that a T1 MRI scan helps evaluate anatomy. T2 evaluates pathology. If you look at the plain X-ray in the upper right, you see a skeletally immature patient, metaphyseal bone lesion, bone-forming lesion. And if you look at the plain X-ray, it may appear that the lesion is not significantly aggressive. But once you get the MRI scan to the left, you see that the lesion is far greater on the MRI scan than you would expect to see on the plain X-ray. When we look at the axial T2 image on the right, then you can see the soft tissue mass. The structures aren't as sharp and crisp on the T2 weighted image as they are on the T1 weighted image for anatomy. But MRI scan really helps you better stage not only an entire bone, but the lesion itself to see the sharp, crisp, defined borders of an osteosarcoma. And often there are characteristics like fluid levels that can help you make the diagnosis. So once we've completed local staging, we go to systemic staging. And the systemic staging orthopedic surgeons use the most are whole body bone scans to evaluate for metastatic disease, skip lesions, especially when evaluating Ewing sarcoma. A CT scan of the chest, which is great for evaluating pulmonary metastases from sarcomas. It's also good as part of the staging for workup of metastatic disease, and some labs can be beneficial. The image on the bottom right shows you a CT scan with multiple pulmonary metastases from sarcoma. Sarcomas tend to create what look like big cotton balls in the lungs, and there will be multiple, often innumerable. A whole body bone scan is sensitive but not specific. And always remember when you're ordering this to get a whole body bone scan, there's no reason to get a focused survey on a patient. You want to look at the whole body no matter what you're evaluating. So it's sensitive but not specific. So a bone scan lights up where there's activity. It could be infection. It could be a fracture that's as old as a year or more. But it does identify multiple bone lesion, and it relies on bone activity and bone flow. So lesions that are very high flow like myeloma, renal cell carcinoma, and thyroid carcinoma may not show up on a bone scan. So it's common for testing to require that you know that myeloma needs a skeletal survey, especially. So a skeletal survey is a plain X-ray of each bone in a single plane from head to toe. And it will show you oftentimes more lytic lesions, especially myeloma, than a whole body bone scan will. One of the common considerations for myeloma is the next step in the diagnosis of a patient with suspected myeloma is serum protein and or urine protein electrophoresis, because you're really trying to diagnose. Remember, a bone scan and skeletal survey are specific. The next step in staging a patient with suspected myeloma is a skeletal survey. And the image to the right shows you within the tibia multiple lytic lesions, also in the fibula, that would suggest a metastatic process. They're a little bit more defined than metastases are, and when you see these punched out lesions, you think of, or should think of, myeloma. Systemic staging with a CT scan. For metastatic disease, you want to use a CT chest, abdomen, and pelvis to look for all those parenchymal organs of origin. For metastatic disease, combining a good history physical and a CT chest, abdomen, pelvis can identify the lesion of origin 85% of the time or greater. When you're looking for metastatic disease for osteosarcoma, chondrosarcoma, and Ewing sarcoma, a CT scan of the chest will suffice to look for pulmonary metastases. Remember, a patient over 50 with a lytic bone lesion needs a CT chest, abdomen, pelvis next for any systemic staging, and likely it will identify the lesion. So for systemic staging, you may see PET scans as a distractor on an exam. It's not common to go right to a PET scan seeing a lytic bone lesion. It's not financially advantageous, and often insurance companies deny it off the bat anyway. Although the 18F FDG is supposed to be pretty specific for cancers, it's not. We see synovial proliferative disorders like PVNS light up frequently in patients who are getting PET scans, and we have to kind of run down that diagnosis. So although it's most sensitive and specific for malignancy, it's not 100%, and you do see false positives. CT scan is performed in conjunction with the PET scan so that you can evaluate the lesion to see whether it is avid or false positive. And it's the most useful for melanoma, lymphoma, and carcinoma of unknown primary. So the majority of the time, the pathologist should be able to tell you you're dealing with breast cancer, lung cancer, or otherwise, but often times you may get an adenocarcinoma unknown primary and use a PET scan to look for those lesions. A hidden tonsil, squamous cell carcinoma, or GI cancer may be found. Labs that may be helpful for orthopedic surgeons in evaluating bone or soft tissue lesions. A CBC SED-rate C-reactive protein are helpful for evaluating infections. Serum protein or urine protein electrophoresis evaluate myeloma, and you're looking for your gamma monoclonopathy, IgG or IgA most common. And then a PSA may or may not help in detecting prostate cancer. Some of the more common labs that can be helpful for patients include an 1122 translocation, the X18 SSX1 SYT. There's also 123 for synovial sarcoma. Retinoblastoma and P53 are particular to osteosarcomas. ESR-CRP can be elevated infection in Ewing's. It's very difficult to determine sometimes whether you're dealing with an infection or Ewing sarcoma because they look the same until you do a biopsy and can see your mixed inflammatory population in infection versus small round blue cells in Ewing sarcoma. Serum and urine protein electrophoresis for myeloma, and PSA for prostate. This is an overview of the staging studies that can be performed for patients with suspected bone or soft tissue lesions. The outliers that you will see are that a CT chest will suffice for everything but metastatic disease, which needs a CT chest, abdomen, pelvis. Whole body bone scan will help in metastatic disease to find other lesions. It also finds skip metastases in Ewing's and osteosarcomas. That does not apply to chondrosarcomas. And then a bone marrow biopsy is helpful with Ewing sarcoma, and in particular for metastatic disease myeloma. So it's your hematopoietic tumor, not with lymphoma. Once you have done your local imaging, systemic staging, labs, and full evaluation, the next step is a biopsy, and that can be performed either with a fine needle aspirate, a core needle biopsy, or even an open biopsy. And the things to consider are either having knowledge of what end result or end surgery a patient's going to have and what that entails for a biopsy. Making a longitudinal incision, avoiding critical structures, that is neurovascular bundles, because when you go back to do surgery and remove the biopsy tract, you want to take whatever structures are underneath, and if you biopsy close to the neurovascular bundle, it will require resection at the time of final definitive surgery. When you're dealing with a bone lesion, biopsying the soft tissue component is ideal when it's present because you eliminate the risk of a pathologic fracture, most likely, because the bone is weakened when the cortex is disrupted. And then you want to maintain strict hemostasis. This should make sense to avoid contamination iatrogenically by creating a big blood pool and then spreading tumor around. So incisional and excisional biopsies and the difference. An incisional biopsy occurs when you're unsure of the diagnosis and the lesion is bigger than 3 centimeters or 1.5 centimeters in the hand and foot. And an incisional biopsy follows all the principles we just discussed. Longitudinal incision, considering the future surgery that will be performed for the patient, and you want to take a good amount of tissue, performing quality control to look at the tissue under frozen section evaluation to ensure that you have healthy living tissue that can be evaluated. This is in contrast with an excisional biopsy. When the lesion is less than 3 centimeters and the incision you're going to make is going to be as big as it would be to do a biopsy, you want to go ahead and remove the mass. Now, if the lesion is less than 1.5 centimeters in the hand and foot, this can be considered as well. The point of an excisional biopsy is that no tissue is left behind. Doing an excisional biopsy means that you have the expectation that no one would ever have to come back to remove any further tissue because it was all removed with a negative margin at the time of surgery. And this is where sometimes people make the mistake of thinking they shell out the lesion and don't take an appropriate margin when they are performing an excisional biopsy. Once the biopsy is performed, there's a lot of processing and evaluation that goes on, and currently the pathology doctors less and less rely on the appearance of the lesion microscopically and the morphology, and more on the immunohistochemistry. So it's much more common now to look at genetic translocations and immunohistochemistry than it is to just look at the morphology to determine the diagnosis. Here are some of the common immunohistochemical tests in the tumor they correspond to: smooth muscle actin and leiomyosarcoma, Desmond and rhabdomyosarcoma, S100 and schwannomas or malignant peripheral nerve sheath tumors. CD34 and CD31 are vascular markers, so we see them in hemangiomas, hemangioendotheliomas, and angiosarcomas. And beta-catenin, a membrane marker for the Wnt signaling pathway, is stainable and definitive for fibromatosis. CD99 is still a good item to know with Ewing sarcoma and peripheral neuroectodermal tumors. Keratin for epithelioid synovials and carcinomas. Epithelial membrane antigen for epithelioid and synovials. And MyoD1 myogenin for rhabdomyosarcoma. Vimentin is pretty specific for soft tissue sarcomas. This is just an example of the immunohistochemical staining for CD99 and Ewing sarcoma. And the chromosomal translocations, again, becoming much more common. If you'll note, there is no known translocation for osteosarcoma. This can be a great distractor on your exam. Chromosomal abnormality in the gene involved are seen here. The more common one, Ewing sarcoma. Another common one is the synovial sarcoma with the X18, SSX1, SYT genetic abnormality. It's helpful because this is one of the most common ones. Testable for soft tissue sarcoma is a synovial sarcoma with these translocations and chromosomal abnormalities. I've been told that the Pax-Fucker gene with alveolar rhabdomyosarcoma, the T213, PAX3 FKHR, can be seen as a distractor on the exam more and more. Here are those most common ones. And then you can filter through these to see syndromes of musculoskeletal malignancies and diseases. So it may help you to diagnose a bone or soft tissue lesion, as you know the patient may have a particular syndrome or musculoskeletal malignancy. Leaf-Romani is a more common entity to be seen. The genetic association is a P53 tumor suppressor gene mutation. We see this with osteosarcomas. Another one I see more and more is Rothman-Thompson, the RECQL4, RECQL4 osteosarcoma. These patients have sun-sensitive rashes and prominent poikiloderma and telangiectasis. Hand-Schüller-Christian's disease, letter of Siwi, are easily testable, associated with Langerhans cell histiocytosis. They do not have a known genetic association. The neurofibromatosis and the NF1 gene are strong associations. Don't forget your metastatic bone disease and how easy it is to work this up. It's super common, and you're likely to see it on any exam. Patient greater than 50, lytic bone lesion is met till proven otherwise, especially if the patient has a previous history of cancer. Here is the lytic lesion seen at the red arrow. We talked about a bone abnormality with pain associated as a pathologic fracture. Pathologic fracture can be non-displaced or displaced. In this case, this is a displaced intertroch subtroch femur fracture. It's lytic in nature, so follow your studies for metastatic bone disease. CT chest, abdomen, pelvis, whole body bone scan, any disease-specific tests that may apply like PSA or otherwise, and then a biopsy. Your common mets: prostate, thyroid, breast, lung, kidney. P.T. Barnum likes kidney. Some tests that can be helpful: PSA, ultrasound to look for thyroid nodules, mammogram for the breast, CT chest, lung, CT abdomen, kidney, SPEP, UPEP, skeletal survey we discussed. In lymphoma, you may see the adenopathy in a CT chest, abdomen, pelvis. Once you do perform a biopsy, you should never see nests or glands inside of a bone. Here we see the nests and glands that are basically destroying the interface of the mature lamellar bone. It's the immunohistochemistry that will differentiate the type, whether it be lung, kidney, breast, or otherwise. When you're taking care of patients with metastatic disease, lower extremity lesions with any cortical destruction that are painful need surgery. You want to use everything in your arsenal because you're treating a hostile environment in which the bone is going to be destroyed, so you cannot count on the bone to heal. Use bone cement, fix the whole bone, consider radiation treatment amongst other therapeutic measures for patients. Predicting pathologic fractures can be difficult, and here's an example of a patient who had a nail placed. It is unclear whether iatrogenic seeding occurred at the tip of the nail, but the patient ultimately broke because the whole bone wasn't properly fixed. This patient also did not get good perioperative care to minimize the potential spread and aggressive destruction of the metastatic disease. If you're unsure as to how to operate or when to operate, remember the Morel-Scoring classification, which looks at site, pain, lesion, and the size of the lesion. You can grade these based on impending, borderline, or not impending fracture. And here's an example of how to use that. This is a 57-year-old woman with lung mets to the femoral neck. It's peritrochanteric, so there's 3 points. Functional pain: you'll need the information that the patient has pain with weight bearing or getting up from a chair. The lesion is lytic. It is destroying at least half of the femoral neck, seen on lateral x-ray. This gives you a total of 11, which tells you that this is a patient who should be taken to surgery for fixation of this fracture. Again, this is the introduction to the diagnosis of bone tumors. Now, thank you.